Okay, so whenever we go for, we did ACLS today, and post ACLS, no, we need what is important for us is to do what to do post cardiac arrest. Post cardiac arrest will be asked in exams. Every exam post cardiac arrest will be asked. Let it be ICCM, let it be IDCCN, let it be anywhere. What to do post cardiac arrest? Okay, post cardiac arrest. So we don't want our patients to post cardiac arrest become like a vegetable sitting at home, not moving, not doing anything. So post cardiac arrest becomes an extremely important part of the tracheostomy. Post cardiac arrest. Post cardiac arrest, what is to be done further? Okay, so we'll first hear Elizabeth. Okay, and I'll probably come in the middle for everything. Okay, so Elizabeth, post cardiac arrest care. So this is after return of spontaneous circulation. Return of spontaneous circulation means after we have finished CPR, there is return of pulse, there is a satisfactory blood pressure for at least 15 seconds. Then only it is called as return of spontaneous circulation. It has to be there for at least a minute or two. Okay, it cannot be otherwise called as return of spontaneous circulation. Okay, so let's go ahead.
So this is post cardiac arrest care. I will be touching on the algorithm and just here and there about targeted temperature management, and also we need to know what is the prognosis of this patient. So I will be touching on this. So first, let us imagine we just finished a resuscitation on a cardiac arrest case, and we have we've got the pulse, and we have got a blood pressure waveform is there for say around 1 minute. Okay, and during this time, what is in our mind? So in our mind, all these things are there. At the same time, we are looking at the patient. So we are thinking on all these things like why did the patient go into a cardiac arrest? Okay. So hypovolemia, hypoxia, acidosis, hypokalemia, hyperkalemia, hypothermia. So all these we have to start treating and thinking about it. Tension, pneumothorax, tamponade, toxins, thrombosis, pulmonary or coronary. Okay. Now this is
so what does this indicate? So what will you do? So the question that comes is, you have a patient. The patient was on the floor. He's suddenly arrested. You went on top. You did CPR. You put the tube inside. Return of spontaneous circulation has occurred. You have brought the patient from the top to the down. You have put him on a ventilator. You have maintained the blood pressure. The blood pressure looks like 110. Okay, what do you do next? What are the investigations for this that you will do? So what are the investigations you will send at that moment? See, it's a nursing responsibility and a doctor's responsibility to send investigations that will diagnose these cases, right? So what are you going to do? So what are the things that you do bedside? What are the things that you put in the lab?
So one thing is I want to send ABG and also check the sugars. Then I'll be also sending side by side the CBC and the serum electrolytes.
So you will send sugar, very good. You will send send a CBC. Of course, it's not going to make a difference if it is CBC unless it's trauma. So CBC may not make a difference, but what can make a difference is electrolytes. So what are the electrolytes you'll be sending?
Serum, potassium, ionized calcium.
So ionized calcium, potassium, sodium, okay, phosphorus, magnesium. You'll be sending all of those. Okay, when a patient comes in post cardiac arrest, I need to know calcium, I need to do magnesium, I need to do potassium, sodium, and phosphorus. All these things have to be sent. Okay, these things have to be sent. Okay, so this is 3 investigations that you want to send. In addition to this, do you want to do something further?
Yes, I want to do a sonography also.
Yes, so what is that sonography called as?
It's called as a fast kind of.
It's called as a focus. Okay, so it is an ultrasound that is done at that particular moment. And what do you want to see in the ultrasound?
So I want to rule out like if I'm dealing with a pneumothorax or a pulmonary embolism, if there's any RV dilatation.
So with the ultrasound, you will get a whole lot of information. What do I need to see? So I will want to see as per focus. I will want to rule out pulmonary embolism. Okay, it's first on my card, cardiac tamponade, 2 things and MI. Because these 3 things require completely different management. So I will follow HIMAP. I'll follow HIMAP where I will rule out, so HIMAP we've discussed in the past, that's not the focus of discussion, but during the focus in the ultrasound, I will look for cardiac tamponade first. I look for cardiac tamponade first because cardiac tamponade is something that requires immediate treatment and a needle inside the heart, right, inside the pericardium. So I look for cardiac tamponade. At the same time, I look for pulmonary embolism because that would require again thrombolysis. Third thing I look for is myocardial infarction, regional non-motion abnormality. Okay, so if that is there, patient needs what? Irrespective of what has happened, patient needs to go where? Cath lab. Okay, these are the 3 things with ultrasound I will see. Pneumothorax very difficult to identify in these cases. Very difficult to identify in these cases. But again, you can say I'm going to look for pneumothorax. Next, what else you going to do?
Temperature, then.
If the history suggests If the history suggests of, say the patient has had a poisoning, that is when you start thinking of levels, urine levels, serum levels. You understand poisoning. So if the history suggests of poisoning, I will send all these things. So you understand the nursing responsibilities. This is only, now what else you will do? What else bedside you will do? It's chest X-ray, and chest X-ray is going to take its time then, and ECG. So these few things have to be done. Okay, chest X-ray, ECG, echocardiography, focus which we call. Okay, and all your blood investigations that you just now said. Okay, these are the few things that you 100% want to do. Clear? So without doing these, you cannot progress further, because these are the important parts of the entire story. That's how we want to rule out these H's and T's. Yes, let's go ahead. Then?
Now we will go one by one into the algorithm. So this is adult post-cardiac arrest care algorithm. So in this, as we have discussed, ROSC is obtained, all these reasons of why the patient is in cardiac arrest is in, we are thinking on those things. At the same time, we need to look at ABC again. So A is airway. Okay, supposing you have been bag and mask ventilating the patient, so you have to think of putting a definite airway for this patient. Then managing the respiratory parameters, that is, once the patient, supposing the patient, you have intubated this patient, then you have to start 10 breaths per minute, keep the SpO2 92 to 98, and a PCO2 target has been given 35 to 45. So accordingly to titrate your ventilatory settings. The third thing is managing the hemodynamic parameters. So if required at this point, you may want to start immediately the inotropic support and fluid resuscitate this patient. Okay, and what is our target? The systolic blood pressure more than 90 and a MAP of more than 65. Then after taking care of the ABC, the next thing that's on the algorithm is the heart, and the next thing will be the brain. So the heart will be, you will immediately obtain a 12-lead ECG. While you are doing the ABC itself, the other person has to start taking the ECG.
No, so let's go one by one to all these things. So you did say manage airway. When you say manage airway, what are we doing? We are actually putting a airway and looking at ETCO2. Okay, manage an airway. Second thing, when we say respiratory parameters, how do you set the ventilator here? How do you set the ventilator? You pen? Like here?
Yes.
How do you set the ventilator here? So you said you are right on the fact that you want to manage the respiratory, but manage means what? What do you do? So you have put the endotracheal tube in place. You have checked the endotracheal tube using ETCO2, right? So in the respiratory parameters, you want to set the ventilator now. How do you set the ventilator? What will be your mode? Mode that you're comfortable with. What is the mode? Volume control. You're comfortable volume control now. Then FiO2. I want to keep the FiO2 to keep the saturation more than 92. So what mistake you can do is keep it at 100% and forget. You should not do that. Okay, we have to keep the FiO2 in such that the saturation is more than 93%. We don't require FiO2 to be 100%. We don't require it. It is not. In fact, if you keep FiO2 for 100% for more than 1 hour, 2 hours, which might occur in these situations, it can be disastrous. It can be dangerous. We don't want to do that. So I want to keep the FiO2 93%. Important. What do I do with the respiratory rate? I keep the respiratory rate in such a way that my ETCO2 is between 30 to 35. I keep my respiratory rate and tidal volume will always be at 6 ml per kilogram. But I'll keep my RR so that my ETCO2 remains between 30 and 35. What does this imply? That my blood PaCO2 is 35 to 40. This implies that my blood, my ETCO2, the PaCO2 in the blood is 35 to 40, which is normocardia, which is called as normocardia. If I keep my ETCO2 as 30 to 35, my PaCO2 will be 35 to 40. 5 plus hota hai. Clear? Clear on this? So, what will be my ventilator settings? Clear? To facilitate these ventilator settings, do you need to give sedation here? Yeah, so as far as possible, I want to avoid the sedation. As far as possible, I want to avoid sedation and neuroparalytic agents. So, avoid sedation and neuroparalytic agents because you want to monitor the neurology. Since you want to monitor the neurology, I want to avoid a neuroparalytic agent or a sedative agent. Clear on this? Now, you did mention about the fact that you want to maintain the systolic blood pressure to be more than, the mean arterial pressure to be more than 65. How will you do that? What is the drug you would use? Noradrenaline. So my drug of choice would be noradrenaline. A corollary to that is, if by any chance you have a patient who is having pulse rate that is low as well as BP that is low, I may want to use adrenaline. Why? Because adrenaline has got a beta 1 and a alpha 1 effect. It has got a beta 1 and an alpha 1 effect, whereas the beta 1 effect of noradrenaline is not very good. Right? So when I say beta, what are we looking at? Chronotropy as well as inotropy. Alpha, when I am looking at, is vasopressor activities. Alpha is vasopressor activity, beta is chronotropic activity or inotropic activity. Clear on this? Just to make a little bit more simple, adrenaline at lower doses will give you beta 1 action. Adrenaline at higher doses will give you alpha action. Right? So if the pulse rate is low, give the lower dose of beta. Clear on this? Adrenaline. So I will use noradrenaline by definition. But if I have this kind of a scenario, I may want to use adrenaline. Clear? To maintain the mean arterial pressure of more than 65. Right? Let's go ahead.
So if the patient breathes spontaneously and is fully awake, we can put the
So,
patient on an NIV.
Yeah, so no. So ideally now, what has happened over here, if you have had a CPR, ideally you should be intubating your patients because we have to find the cause now. So secure the airway. You understand? So patient has had a cardiac arrest, okay, that doesn't mean he's woken up so I'm okay with it. No. So if you find the cause, then it's a different situation. But more likely than not, you will not have a cause in hand. Right? And I want to investigate my cause. The next arrest, next CPR, next time he might not revive. You understand? So ideally we want to intubate these patients, find the cause and then decide on the extubation. Okay? You must understand what is happening here. Patient has become cardiac arrested. Why? Because there has been no perfusion to the organs, there has been no perfusion to the heart, there has been no perfusion to the brain. That is why he is basically arrested. So the minimum amount of perfusion pressure required in the heart is 15 millimeters of mercury. He is not even getting that much. Since he is not getting that much, that is why he is arrested. Arrest, we are not talking of syncopal attack, we are talking of arrest. Where arrest means there is a stop of the entire circulation. So I don't know the reason, I have to figure out the reason. And to figure out the reason, it is important that the next arrest is averted somehow. And the way I can do that is put the tube in, let him be ventilated and figure out what is happening. Okay? Clear on this? Yeah.
So this was called the initial stabilization phase. After this, once you take the ECG, so after ECG comes this. So now in the ECG, if there's anything positive, so if you're seeing a ST elevation MI, or if the patient is in unstable cardiogenic shock, or if the patient requires a mechanical circulatory support, immediately, of course, you need to put in your cardiac expert consultation.
Chandrasekhar, you told Vajanti only on the left, na? Not on the right.
Yes. And cardiac intervention. That will mean immediately shifting the patient to the cath lab. Then next coming to the brain. So once the heart, you have checked in the major things in the heart, then you go into the brain. So brain is following commands, is going to give you a clue. So the patient is fully awake. Then your objective is to take care of the 5H and the 5T. Basically it's that. And then supposing the patient is not following the commands, then you can consider the patient as comatose. Okay. So if the patient is comatose, then what do? Immediately you think about your fridge. Okay. So you have to remove everything. TTM, that's targeted temperature management. Okay. Then you have to that involves basically what is targeted temperature management is getting down the temperature of this patient between 32 to 36. That's what they have said. How do you do it? First, you expose the patient. Then all of you know that we put the wet blanket on the patient, we put ice packs on the patient, we put IV. Just now you said everything, right? We put IV cooling procedure on the patient. Okay. Then we also think of obtaining a brain CT. Obtaining a brain CT.
So when you come here and you do an ECG,
Yes.
when you come here and do an ECG, you find ST segment elevated myocardial infarction. Irrespective of what the status of the brain, you don't look at it. So the important thing that you're understanding is, whatever the brain may be, I'm still going to go for a PAMI or a angioplasty. I don't wait for the patient to be awake. Others you might think, I did CPR, let the patient get awake. Others, what is the use of going for the angioplasty? It is not like that. So the moment as the patient has a cardiac arrest, you will, and you find that this ST segment elevated myocardial infarction, even if there is ongoing CPR or the patient is completely comatose after the CPR, you will still first rush the patient to the cath lab to get the artery to be opened up because the cause has to be taken care. That's why this is coming before. It's not coming here. Otherwise, you might think follows commands, no, yes, then I will do it. No, it's not like that. It is right here. You understand, huh?
Yes. Then, targeted temperature management, that I'll be talking a little more on that. Then obtain the brain CT. So now that's not that is a little challenging decision because the patient may be hemodynamically unstable. But probably we can do a continuous EEG monitoring, that can be possible at that time. And other, that is basically again treating the underlying causes, like why the patient went into cardiac arrest.
Now, so there's some people important over here. So these things have to be done in the first 24 to 48 hours. Both of these things. These things have to be done in the first 24 to 48 hours. Because if there is a big brain bleed or something like that, that needs to be ruled out. Okay. Similarly, EEG monitoring can be quite cumbersome. What is going to happen with EEG monitoring is, if this patient has got hypoxia, why do we do EEG monitoring? Actually to find what?
Hypoxic brain injury.
No, it's not hypoxic, it's to understand prognosis. It's hypoxic brain injury, you cannot diagnose with an EEG. Okay, what if I want to figure out what is the prognosis? And to find the prognosis, one of the ways to do it in the first 24 to 48 hours is to do an EEG. Okay, what will the EEG tell us? The EEG will tell us whether there is burst separation or not. Now, what are the challenges when you are doing EEG? What are the challenges? Can you tell me some challenges in doing EEG in such patients? If, say for example, patient is hypoxic. What is going to happen is, what is an EEG? EEG, you put these things, right? And then the EEG is done, right? Now, very often what is going to happen to these patients is, they may be either shivering or they may be either convulsing, myoclonic. ऐसे ऐसे convulsion हो रहा है, ऐसे ऐसे हो रहा है. The myoclonic jerks are happening. So at that stage, you can't do the EEG because the EEG wires are attached, and if it shakes like this, the wires will not be able to give us the right answer. Right? So this is the time that if the patient is having a myoclonic jerk, the EEG person will come and tell you, no, I cannot do it because he is convulsing. You understand? It is not possible to do this. But I want to do it because I want to find burst suppression hai ki nahi hai. I want to find out background noises come down or not. If background noises come down, burst suppression has occurred, means the overall prognosis is poor 95% of the times. Right? So what do I do in these cases? I give him something to stop this. I give him maybe a paralytic agent. So this is the only place where I probably will give a paralytic agent. You understand? I'll give a paralytic agent of Vecurons 8 milligrams and tell the EEG technician, please do the EEG because I need to know the background. You understand? So when I'm doing the EEG, it's very important. Why I'm doing the EEG? To find the prognosis in the long run. Hypoxia will not manifest very early. For manifesting hypoxia and imaging and things like that will take 4 to 7 days. Right? Okay. Then?
This is also then treating the reversible cause. Then
Yeah.
if the patient is awake, then again it goes into treating the cause.
Yeah.
So this is.
So now before we go to this, how do you assess the prognosis of this patient? How do you you're coming back? Okay.
So again, since now we understood the algorithm, so now I'll be quickly going through. So what is the priority of doing all this? Why are we immediately doing all these interventions post cardiac arrest? So it is, first of all, you want to prevent the next cardiac arrest. Okay, define the underlying pathology, limit organ damage, and predict the non-survivors. So accordingly, simultaneously we'll be starting to counsel the family also. So prevent further cardiac arrest. So what do we do in that? So we optimize the FiO2, like Sir has said, like you maintain a target SiO2 and SpO2 more than 93. Okay, prevent hypoxemia, protective lung ventilation comes in here, and commence.
So sedation. Here, if you want to do sedation, say for example, you want to, there is asynchronicity happening, ventilator is not working well. What kind of sedation I will use here? I will use sedation that will be quick in and quick out. So I will not use benzodiazepines like lorazepam and long diazepams and things like that. I will be using something that will go in and come out quickly, like Dexen, like dexmedetomidine I will use, like ketamine, switch in and switch off. Yeah, so these are the drugs that I will probably use. I will probably use dexmedetomidine, I can use ketamine, but probably I will not use lorazepam and I will not use all those big benzodiazepam and diazepam and things like that. If I want to commence sedation. You may want to commence sedation because the patient is not okay, not breathing well with the ventilator and things like that. So that's when you use those particular medicines. Okay?
Then we have a target CO2 that they are told. So you ventilate to normocapnia, you titrate your respiratory rate, tidal volumes. Then you correct the electrolyte, the glucose, and you can give antiarrhythmic agents if you have dealt with the arrhythmia.
So what is the dose of ketamine you want to give here?
0.3 to 0.5.
0.1 to 0.3. The dose is different. The dose when you are looking for sedative is 0.1 to 0.3 milligram per kilogram. 0.1 to 0.3 milligram. मतलब 5 milligram, you know, if it's a 50 kilo individual, 5 to 15 milligram per hour is what it will be. 5 to 15 milligram per hour. Good. Hi. Oh,
Defining the underlying pathology. So we diagnose and treat the cause, may need a PCI, like how we said, like if there's a PE, then you require thrombolysis, and if it is a MI, then you think about sending the patient PAMI. Treat the complications, that is if you're dealing with heart failure.
So that's where it comes in, you know. These complications are of what? Of your CPR. Okay, so if once you do your CPR, the next thing you want the X-ray is for this reason. Okay, because you have done CPR, there's a possibility of rib fracture, there's a possibility of pneumothorax, there's a possibility of any other thing that has occurred because of the excessive amount of compression that we are doing. That's why you want to do the X-ray over there. Okay, clear? Yeah.
Then of course, if you require a mechanical cardiac support, a cath lab on an ECMO for refractory errors, and by the time you're already assessing the neurology. Okay. Then, so this is on how to limit the organ damage. So if the patient is unconscious despite the ROS being achieved, then you want to commence the targeted temperature management. So there are multiple studies that have been done on this. Again, I will be touching on those studies briefly. So until 2013, the approach is to cool this patient. They are mentioned in the algorithm, 32 to 34 degrees for 24 hours. So after there's a trial called a TTM trial. So they have mentioned a temperature of 36 degrees Celsius, which is expected to be widely used as a target. So they have said that around 36 degrees Celsius is beneficial for the neurological improvement.
So this, let me, you have to start again?
Not in,
okay.
I just touched upon it.
It's touched upon me? Yeah.
So, like we have already discussed, like how do we do this targeted temperature management. So first thing is you expose this patient, okay, then you have, of course, first put a rectal probe, you expose this patient, you put a cooling blanket, cold IV saline 4 degrees Celsius that we are giving. And during all these things, there will be a component of shivering. So you will know how to control shivering. And what is like slow rewarming that is done later, control slow rewarming that will be done later on, like 0.25 degrees Celsius is controlled. It is titrated as per your rectal probe, you have to see and titrate it. And during this time, of course, we'll be thinking of putting a central line, arterial line, and invasively monitoring this patient and targeting the MAP. Okay. So this is a little bit about targeted temperature management. Again, okay, so. So in targeted temperature, I just want to talk about how to manage shivering. So shivering occurs at a cold temperature of 35.5 degrees Celsius and may be counterproductive to the induction of cooling. So there are different ways that we can control this shivering. First, they have mentioned like you can start paracetamol, 1 gram QDS. Okay, and maintain magnesium levels of more than 0.8 millimole per liter. And supposing your shivering starts, then you have to wrap the hands and feet with warm towels, start Dexmed infusion or propofol infusion if Dexmed is contraindicated in case of bradycardia, fentanyl infusion or ketamine infusion. And if all else fails, you can give a muscle relaxant.
So this is so important, you know.
Yes.
So when you go to this therapy, you know, when you say shivering, this is actually got a scale. It has got a scale called as BSAS scale, Body Shivering Assessment Score. BSAS scale. Okay. Now what is that scale? You know? That scale actually says that if there is no shivering, it is scale 1. Okay. If it's 2, class 2, it means that the neck and thorax on touching has shivering. Class 3 is the neck and the thorax is shivering any which ways. You don't have to touch, it just shivers. And class 4 is the whole body shivering. So you have BSAS scale. BSAS scale, it is very important, okay, because this will prevent your cooling if it starts shivering. Okay, so scale 1 says what? No shivering. In class 2, what is happening? In severity class 2, what's happening? Just the neck and thorax on touching shivers. 3 is when neck, thorax is shivering on its own. And class 4 is whole body shivers, BSAS scale. Okay, so that's why you should go from this to here. Important what you must understand is paracetamol is not dosed when there is fever. Paracetamol is dosed 6 hourly. You understand? You are dosing paracetamol 6 hourly, 1 gram 4 times a day. That is all. It is not only when fever comes. You dose it regularly, paracetamol. Which patients you will not dose it at 1 gram? This is 4 grams going now. So if the patient has got alcoholic cirrhosis, if the patient has got hepatitis of some origin, there how much I will use? I will use 2 grams. From 4 grams I will use it as 2 grams. The maximum I can use is 2 grams, right? And this is very important. This is very important. So this is one place, that's why you need the magnesium levels. Where you want to keep the magnesium more than 0.8 or more than 2 milligram per dl. Isn't it? 0.8 is equal to 2 milligram per dl. So I'm going to keep the magnesium more than 2. So if I have a patient who is coming from a post-cardiac arrest, I want to keep the magnesium more than 2. That is very clear. Clear? More than 2. Okay. Then this, why is this doing? What is this? Why is this being done? It is saying warm hands and feet. If the patient is shivering, warm hands and feet with warm towels. Because what happens is once you warm the hand and feet, the body gets tricked that it has become warm. Let us not shiver anymore. Samajh mein aa raha hai? You're not covering the whole body. In targeted temperature management, when you want that the patient should stop at shivering, okay, what you should do? Just cover hands and feet with warm towel. So when you cover the hands and feet with warm towel, only that much part, because you don't want it to warm up. Understanding, you don't want the patient to warm up because you want the temperature to be low. So when you put it on the hands and the feet, the body gets tricked to feel that, okay, I don't need to shiver anymore, because shivering is a mechanism to actually increase the temperature. You understand? So what I will do? I will wrap my hands and feet with warm towels. Now here, in tier 2, when this is occurring, when the shivering is occurring, the next drug I would want to use is actually dexmedetomidine followed by ketamine. I want to avoid the opioid as much as possible. Same reason. If I give opioid, the neurology will take a longer time to recover. You understand? I want to avoid it. So the first thing I would use is dexmedetomidine in large doses. Then the next thing I would use is ketamine infusion. Now the dose for ketamine is different here now. What was the dose we said? 0.1 to 0.3. Now the dose over here is 0.3 to 0.5. Okay, so the dose becomes higher. So if you have started sedation at 5 milligram per hour, I will go to 15 milligram per hour immediately if the patient starts shivering. You understand? The dose is different. Okay, when we said here, a sedation at that time was 0.1, 5 milligram per hour. Now we are going directly to 15 milligram per hour, which will prevent shivering. And then the next step over here would be increasing the magnesium further higher. So I will move from 2 to I will move to 4, double. So it's almost double. You understand? So I will target the higher magnesium which will prevent the shivering. Okay? And why do you think shivering is going to occur? Because you are keeping it at 36. You know, if you are at 33, you will probably not shiver. If you are very cold, you will not shiver. But if you are 36, 37, you will shiver. You know, that is the reason that you have to be careful about this, what you are going to do. And the last thing I would do, in tier 3, I will probably move this fentanyl over here. Because that is where I will give a bolus. A bolus of fentanyl will actually cause the shivering to come down. That is why we say avoid the infusion. You understand? Avoid the infusion. So in order for prevention of shivering, keep magnesium up. Okay? Dexmedetomidine, before which warm hands and feet, ketamine, in higher doses, then fentanyl boluses, and keeping magnesium more than double. That is the order to prevent shivering. Clear? Yeah. And so the temperature, I would say, the temperature you should target is 37.5. Because why? What we know is that it is 36 to 37.5. This is the target temperature that we want to target. We want to target it from 36 to 37.5. 33 degrees is what initially we used to do. We initially used to keep it at 33 degrees. Okay, now after the TTM2 trial came in, we know that we don't want to keep it at 33. We want to keep it from 36 to 37.5. Most importantly, I want to avoid it from going more than 37.5. Most importantly. You know, I want to avoid it from going more than 37.5 with whatever techniques I can. Clear? So, why to target 36 if shivering is going to become too much? Keep it at 37.5. Target at 37.5. You understand? And let it not go higher. Clear? Huh? Yeah.
So these are different trials that has been done regarding this targeted temperature management. So first in 2002, there was this HACA trial that was done with outside hospital cardiac arrest patients. So they have taken two groups of patients with 24 hours of cooling. One was kept at 32 and 34 and other at normal temperatures. So this demonstrated that keeping at lower temperatures had favorable neurological outcomes. The next trial was in 2013, which is the TTM trial, which was repeated again now recently in 2021. So in 2013, again with outside hospital cardiac arrest patients, they tried to cool these patients at one group at 33 degrees and the other group at 36 degrees. So 33 degrees they maintained for 36 hours and 36 degrees Celsius for 72 hours. So they proved that normothermia is so basically there was no benefit giving this lower temperatures to these post-cardiac arrest patients. The next was in 2019 where they incorporated in-hospital cardiac arrest patient, which is called Hyperion trial in 2019. So here they kept the patients, one group was at, so this is 24 hours of 33 degrees Celsius. Then they maintained normothermia for 24 hours versus another group where there is normothermia for 48 hours. So they demonstrated significantly improved neurological outcomes in the treatment arm. And in 2021 was a TTM2 trial. Again, there is a out-of-hospital cardiac arrest patient, where they kept the patients for 28 hours on 33 degrees Celsius. Then they rewarmed the patient until 40 hours. Then normothermia to 72 hours. And the other group was normothermia itself, 36 to 37.7 for 72 hours post cardiac arrest. So they found that there is no difference in morbidity and mortality in these two groups.
So what is the bottom line? This is the bottom line.
Yeah.
The bottom line is you keep it between 36 to 37.5 for how many hours? At least for 40 hours. Because the trial actually did it for 40 hours. The trial actually did it for 40 hours. Okay, so 36 to 37.5 for at least for 40 hours. That is the answer. Okay, huh? Yeah. That means don't let the temperature go up. That is the real thing. Let it not go more than 37.5. 37.5 is normal, isn't it? Huh? Yeah.
So in that case, we may not even give the IV whole saline and all.
But when usually what happens is once you do your CPR, your temperature will be 38 and 39. Usually once your CPR is done, this will be the septic patient or whatever, the temperature will be 38 and 39. So when you put a cold temperature rise, it's 38 and 39. And then when you have a difficult time getting it back to 37. No, this is what is occurring. You understand? We are not reaching 34 at all. So to get that, and has to be done quickly. That is why we need to do it quickly so we get into that range. To understand? Huh?
Okay, so one thing I missed out was, okay, what does the therapeutic hypothermia do? What are the proposed benefits behind this? So, first thing is reduces the cerebral metabolic rate, okay, and reduces the ischemic perfusion injury by it improves the glucose metabolism in the brain, and it can cause upregulation of something called cold shock proteins, which is protective against ischemia, and it results in improved overall care. Now we will go into the prognosis. So prognosis of the patient. So now this cardiac arrest happened. Now it's already simultaneously one of us is already talking to the family. So we need to counsel them accordingly. So what is the prognosis? Prognosis involves the consideration of the underlying cause of the cardiac arrest. Okay. And the presence of comorbidities, like if the patient has cancer or dementia, the use of TTM, okay, that will be again assessing neurologically. The patient will be assessed after this TTM has been started, and that will also give us an idea of prognosis and features of cardio. Okay, what is the features of cardiac arrest and cardiovascular assessment? So there are some predictors of poor prognosis. For example, that is in 72 hours. Okay, you've done your TTM. In 72 hours, there is no pupillary response or there is no corneal reflex. These are again markers of poor prognosis. There is no motor response or there is an extension to pain at 72 hours.
So this is what we say for 3 days. You understand? So after a cardiac arrest, never give any prognosis till 3 days pass, because you will be certain about prognosis only when you find an absent pupillary response or an absent what's corneal response.
Corneal reflex.
How do you do that?
So with a cotton swab, we have to just touch the cornea.
Touch the cornea, not conjunctiva. Very often you end up touching the conjunctiva. Okay, touching the cornea, and you see blinking. So absence of pupillary reflex, absence of corneal reflex is 99%, almost 95+% sensitive of extremely poor prognosis. And the last most important thing, because we are putting these patients on sedation and ketamine, that's why it becomes very important, because pupillary corneal reflex will still remain. Pupillary corneal reflex will still remain, though sedated or whatever. But this will get abolished. Okay, that is why we need to have shorter acting sedative agents where this response, no motor response or extension, becomes extremely poor prognosis, again above the range of 95%. So if the patient is extending to pain, anything less than a flexion or localization is poor prognosis. Poor prognosis means they may not get into functional activity. Okay, at 72 hours. Yeah.
Then the patient has myoclonic status epilepticus, that means generalized convulsions in the face, extremities, and it's continuous. It's happening minimum of half an hour. Bilateral absence of cortical somatosensory electrical potentials at
Potentials.
potentials at 1 to 3 days. And there is a particular level that we can check.
It's not available.
And what are the predictors of better prognosis? So, supposing in 2 days, we are finding that the patient has slowly got back the brainstem reflexes. So, what are brainstem reflexes that papillary corneal and
Pupillary corneal
and oculocephalic reflex. With all then a return of purposeful response in 24 hours. Primary pulmonary event that's leading to hypoxemia, that has a better prognosis. Hypothermia at the time of arrest, like cases of drowning, and younger age groups.
Yeah, I think that's it.
Yeah, so actually prognosticate at 3 days, and perform the TTM as we keep a target of 36 to 37.
Because it is going to take some time. 40 hours later, you will start slowly warming the patient. So take it. So, go to any questions on this?